Hi, my name is Sarah Russell. I am a speech-language pathologist and a swallowing specialist at Michigan Medicine, and I am the primary speech pathologist on the lung transplant team. I am going to be reviewing swallowing issues related to lung transplantation. We will be reviewing why swallow function is important at all. We're going to go over some pre-transplant testing you might go through and post-transplant testing of your swallowing, and then review some swallowing precautions that you might need after your surgery. Let's review some important terms. Oropharyngeal dysphagia is a term for difficulty swallowing food or liquid or pills through your mouth and your throat. Oropharyngeal dysphagia is something that a speech pathologist evaluates and treats. Aspiration is the term for food or liquid or foreign body potentially going down the wrong pipe into your airway when you swallow. You can also aspirate stomach contents if you have reflux. And the term GERD that you might be aware of stands for gastroesophageal reflux disease. So why is swallowing function important for us to evaluate for lung transplant? Prior to your lung transplant, many patients who have issues with their lungs and end-stage lung disease can have gastroesophageal dysfunction. And this might turn into GERD or esophageal dysmotility that might impact your lungs after your surgery. After your lung transplant, GERD and esophageal dysmotility and delayed gastric emptying are frequent, and there's an increased risk of aspirating stomach contents from reflux, which can contribute to rejection of your new lungs. Additionally, after lung transplant, you may have difficulty swallowing food or liquid through your throat safely. New research has shown that up to 70% of patients can have an abnormal swallow after transplant that can result in aspirating food or liquid or resulting in food or liquid remaining in the throat after the swallow due to weakness in the throat muscles. Because of the surgery and some of the interruption of the nerves, most patients after lung transplant might have silent aspiration, which means food and liquid can get into your airway and you will not feel it to cough it back out. Post-transplant, your cough might be weak, and you may not have your cough reflex for a period of time while those nerves are regenerating. There is a risk of vocal cord movement issues that can result in a hoarse voice after surgery. There is some research that has shown that up to 25% of patients might have impaired vocal cord movement after their surgery. All of these issues of difficulty swallowing after surgery are related to GERD, nerve injury during the surgery, trauma from the breathing tube, or the TEE ultrasound probe that is in place in your esophagus for the surgery. There is some testing that you will go through prior to your surgery to evaluate your esophagus. The first test that many people go through is called an esophagram or a barium swallow. And this is an evaluation of your esophagus, and we're primarily looking to see the motility and risk of reflux with this examination. The esophagus is a tube that connects your throat to your stomach. During this test, you're going to drink a variety of barium mixtures while moving X-ray pictures are taken while you swallow. Some patients where there is a concern for dysmotility in the esophagus might have additional testing called esophageal manometry. And this is accomplished by placing a small probe from the nose down the throat, through the esophagus into the stomach. You will drink a little bit of water while the probe measures pressures in your esophagus. Additionally, some people might go through testing called a pH probe or esophageal pH monitoring, and this is another way to evaluate your risk of GERD, that esophageal reflux, and to determine if you may need any more management of your GERD prior to and after your surgery. After lung transplant, there is more of a focus on your ability to swallow through your mouth and your throat to avoid aspiration. In the ICU, after your breathing tube is removed and you're feeling well and breathing comfortably and your pain is controlled, you will meet a speech pathologist who's going to do additional testing to determine if you can safely start swallowing food and liquid and pills. The test that we do in the intensive care unit is called a FEES, and that stands for flexible fiber optic endoscopic exam of your swallowing. This allows us to get a bird's eye view of your airway and your throat while you swallow water and food colored with blue food coloring. This test involves a small flexible camera that goes through your nose to give us that bird's eye view of your throat. Some patients who have some difficulty swallowing on that initial FEES exam will require follow-up testing. We generally will wait a couple of days to allow your throat to heal from the surgery, and then follow up with a test called a video swallow study, or a VFSS. This again is done by a speech pathologist, and this test is done in GI radiology, the same place where you may have had your pre-operative esophagram. This test gives us a nice side view of your throat and your esophagus while you swallow some barium and barium-coated foods. Here is a picture of a couple of my colleagues doing a FEES examination in the ICU. We will come to your bedside with our nasoendoscope and our tower to do the first exam, so you don't have to leave the intensive care unit. Here is a recording of a FEES exam. So we have a bird's eye view of the airway. Right in the middle of the screen, those V-shaped tissues are the vocal cords, and the vocal cords in the voice box sit right on top of the trachea, or the airway. When you swallow, the food and liquid needs to be redirected away from the airway to go behind the airway into the esophagus. On this example, the patient is swallowing some blue water, but you can see some of the blue liquid is leaking into the voice box and getting all the way down and coating the vocal cords during and after the swallow. There's also some pooling liquid in the natural pockets of the throat that suggests the swallow is a little bit weak. This is a person who would likely not be able to start eating or drinking until they had a bit more time to recover. Here is another FEES swallow study showing an example of vocal cord paresis. So because this is a bird's eye view, the left vocal cord is on the right side of the screen. So the vocal cord on the right side of your screen is not moving very well. And again, this can be just a temporary nerve injury from the breathing tube or the surgery itself. And generally, this gets better with time, but may result in hoarseness after your surgery. If you end up having some difficulty swallowing immediately after your surgery, You will likely have a video fluoroscopic swallow study as a follow-up test with us in GI radiology, and this is a picture of what the exam room looks like. We will transfer you into this chair, and you'll remain sitting upright in a chair position for the entire exam, which is different than the pre-operative esophagram where you have to swallow laying down. For the video swallow study, you're going to get a series of barium liquids and barium-coated foods to swallow while we take the moving X-ray pictures of your mouth and your throat. Here is the different view that we get from a video swallow study. And this recording is showing what a normal swallow through the mouth and the throat looks like. Here is an example of a patient who has some weakness in their throat and aspiration. I want you to focus on the contrast moving through the throat and the small amount of liquid that can be seen leaking forward into the airway and dripping down the airway to the left of the screen. As you can see, the airway is right in front of where the esophagus is. There's very little room for any impairments, and it's very easy for food and liquid to potentially go down the wrong way if any of the muscles or nerves are not working perfectly. If you have some substantial difficulty swallowing, you may end up with a temporary feeding tube that goes from your nose to your throat, down your esophagus into your stomach, that can give you food and nutrition and your medications until your throat muscles heal. This is often a temporary solution that is in for a few days to up to a week. There are some cases where post-op swallowing issues are more prolonged, and you may end up with a feeding tube for much longer. But in general, this is a temporary issue that often gets better fairly quickly. Let's review some swallowing precautions and therapy. If you are found to have some difficulty swallowing after surgery, you may go through a little bit of therapy while you're in the hospital, while you're waiting for your muscles to improve. A lot of patients, even if you're not able to start eating or drinking food and liquid, are allowed ice chips. And ice chips are a very small quantity of water, melts very slowly, and it's excellent practice for swallowing, keeps your mouth nice and moist, and gives you a stronger swallow over time until we're able to retest your swallowing. You may be given some swallowing exercises if your throat muscles are weak. Some patients do well swallowing with their head in a certain position, such as tucking your chin to your chest, or if one of your vocal cords is not moving well, we may have you turn your head towards the weak side to swallow the food and liquid down the strong side of your throat. Some people benefit from coughing or clearing their throat after they swallow, swallowing twice, or taking a sip of liquid to wash down food. Some patients additionally may need to take their pills with applesauce or pudding if water or other liquids are still getting into the airway during the swallow. Many times patients might require a diet modification, such as a softer food or liquids that have been thickened to eliminate them from being aspirated. In our hospital, we have several different levels of diets for people who have difficulty swallowing. These are called our dysphagia diets. Our level 4 diet is all pureed food. Level 5 is minced, moist food. Level 6 is soft and bite-sized food, something like a banana. And then a level 7 diet is our regular diet. We do have an easy to chew option for people who may have issues with their teeth. And a lot of our patients will work all the way through these different levels up to a regular consistency diet before they're discharged home. If the regular liquids are found to be aspirated, going down the wrong pipe when you swallow, you may require a thicker liquid. A lot of our patients might be on a mildly thick liquid. This is similar to a yogurt smoothie consistency or something like a tomato soup consistency. It's a bit thicker, travels slower, and is often less likely to go into the airway when swallowed. Again, these are temporary measures that often can be removed as you get stronger and your swallow function improves. Our research is showing that over 90% of our patients completely resolve their swallowing issues by the time they're discharged. There are a few patients who may go home on a soft diet or with thicker liquids while they recover, who may have to come back and see us as an outpatient a few weeks after their discharge for another video swallow study. And there are a few patients who may need another type of surgery on their esophagus to better control acid reflux. Often that surgery, a Nissen fundoplication, cannot be done prior to surgery because your lung condition might not be strong enough to go through a surgery. So that is a potential additional surgery you may need if reflux is a significant concern for you. Here are all of my references, and I want to thank you for tuning in, and I hope you learned a lot. Please feel free to reach out to me for any questions you might have. Thank you.